let me just to give you time to perhaps formulate some questions or whatever. But in a lot of cases, my experience is a lot like Doug's. I probably had a little bit more intense experience because I worked with people that were DID and dissociative disorders in a hospital setting, and it was over the course of about 12 years that I worked with them. So in the hospital setting, we had a dissociative disorders program where I served as the director, and we did groups, we did individual work, and usually in a lot of cases it was really the worst of the worst because it was a hospital and it was someplace safe and secure that people could be at and get some treatment. So I probably over the course of that decade, I easily saw probably somewhere in the vicinity of 80 to 90 patients a year there. So you do the math. We're pushing 1,000 cases that I've been a part of, and seen pretty much a lot of the same things that Doug described. Some of them even a little bit more complicated in the sense that when you're treating people with DID, or even just generally speaking dissociative disorders, in the outpatient setting, you have to have a certain level of safety and security in order for that to even happen. And they have to have a certain level of stability even for that to happen. Oftentimes their lives are punctuated by crises and re-traumatizing and other things that happen as a result of the different parts and things that are active in their lives at the time. So, my experience is a lot like Doug's. It probably is a little bit different. We certainly had. I was fortunate enough to be in a Christian unit, so we had all the same kind of demonic stuff going on in the unit, which kind of freaked out all the secular psychiatrists, which is kind of fun, actually. You know, they didn't believe it happened, and they got freaked out over it. So it was kind of interesting. But and that was that. When I left Illinois to come here to Colorado, I kind of promised my wife I would be done working with DID people. Little did I know that they just decided to follow me. I got here to Colorado and went back into practice eventually. Started working with a young lady who I was sure was PTSD, and lo and behold, surprise, we had DID on my hands and another DID case to work with. So I never am very far away from it, and the experiences, because I did it as long as I did. That when Doug talks about re-traumatizing and secondary PTSD for therapists and things like that, I'm pretty sure I went through all of those things as well. So I've got kind of that perspective on top of it. So, but a couple things that I want to just clarify for you, and one way that I kind of diagram DID is that, I mean, if we were to just say that this is an intact person, okay, and a lot of times it's littered in our language where we say, well, you know, a part of me feels like I want to do this or that or the other thing, and ultimately, in a sense, all information is available to all parts of my personality and my experience, and all memory is available to all places. So I can, if I were to say, you know, tell me what happened to your day from the moment you got up to getting here today, you would be able to give me a relatively continuous timeline, unless you dissociated it in class. But that being said, you'd still fill in the gaps. I mean, the reality is that a lot of the information that I have learned over the years, and even I teach in Cog Psych, is memory is reconstructive. It always is reconstructive. It is not a replaying of an audio tape or a videotape. It is nothing like that. It probably is more like what we use in cognitive psych is a tachysoscope. In other words, it flashes scenes, and then you have another flash, and it looks like it's changed. If you've ever seen claymation, that's essentially how they do claymation. They take a shot, change the characters, take another shot, and they put it in 30 frames per second, and it looks like it's all moving smoothly. Well, people that are experiencing DID experience life closer to like that. But you will have a continuous experience with time. And people with DID a lot of times don't. It is very discontinuous, disjointed, and they fill in the gaps. And so when we talk about time, from now, or let's put past to now and then future, generally we experience time in somewhat of a continuous sort of way. For people with DID particularly, and remember that's the most severe end of dissociative disorders, the way they experience time is a little bit like this, where there are windows in time that they are awake, and then there's gaps in here. And during that time, those gaps, other things happen. They lose time, and like Doug said, one of the alters, and a couple different terms we use. One is called alters, not EAS, alters, or parts. You might put in personalities. Generally speaking, these two terms mean the same thing. And generally speaking, when we define what a personality is, or a part, is that it has a range of emotions, it has a depth of emotions, and it has its own history, behavioral history. That's how we define what a part is. So when Doug was talking about 200 parts, in a lot of cases, we can also have something called fragments. And with fragments, you have kind of a special function part. It doesn't have a behavioral history. It doesn't have a range of emotions or a depth of emotions. It really comes out only for one thing. So if you have a little girl that is getting raped by whomever in in her world, she might have, because of dissociation, and it comes so easily for kids, she might have a part that comes out, separates from what's happening, and handles, in a sense, only that activity, that event. And so a lot of times the numbers for how many parts or personalities tends to get driven up by how we count these fragments. Because in a lot of cases, the actual number of parts / personalities is a lot less. The one case I had that was the highest was somewhere between 35 and 40 parts, all right, personalities. She had a lot of other fragments that would have pushed that number a lot higher into the triple digits. But it wasn't a full-blown part. It didn't, and these parts oftentimes will occupy this space, the gap in time that occurs. And they think that, in a sense, they think they're going to sleep. And I had one DID person that I worked with. Some of you have heard me talk about her before, Maggie, and she had a part named Crash. And when she would go to sleep, she thought she was going to sleep. Well, at that point in time, she wasn't really sleeping. She had switched. And Crash came out, hopped on the metro train, went down to downtown Chicago, partied with all her friends in Lower Wabash in Chicago, and then somewhere around 3:30 or 4 in the morning, hopped on the train, came back, crawled into bed, and Maggie thought she had had an awful night's sleep, which she had. So, yeah. Say again? Yeah, well, let me take that example with Maggie. Crash had his own. Remember, we have parts that are different genders than the host, but had his own history of people that he interacted with. And he had a range of emotions, so mad, sad, glad, bad. He had that entire range, and he had a depth of emotion. So when it went from enraged to just frustrated, and you'd see a pretty full development of a part like that. And he had his own specific history. As a matter of fact, there were times where Maggie would get a phone call, and that was when we had the old, answering machines, and somebody would leave a message and ask for Crash and leave a message and say, call me back at X, Y, and Z. And when Maggie would listen to it, she'd have no idea who the person was or what the phone number was or who they were at all. So the criteria we typically use are those three: range of emotions, depth of emotions, and behavioral history. That's unique to that part. Okay, does that help? Well, the fragment, like I said with that example I used, the fragment is only for some traumatic event, and it only comes out during that time. Only that time. It doesn't develop a behavioral history with people. It's just functional to that time. Yeah.
So it's just like a kid that's being repeatedly abused. They can fragment and just
And that fragment would come out during that time, and the dissociative kid would not undergo what happened. The fragment would undergo it, and a lot of times the fragment would have the history of what happened there, but the dissociated kid would not. Yeah.
So when Maggie would listen to that message, would Crash get the message inadvertently and know what to do?
No, because, and I'll continue this diagram, but because Doug used another term called co-consciousness, and they did not share co-consciousness. So if I were diagramming Maggie in this case, what you would have is these parts and component parts that the walls between them were impermeable. And that's generally when somebody comes into therapy undiagnosed and unaware even that this is happening, this is what it looks like. And the walls between the parts are completely impermeable. There's no communication, there's no listening in on each other, there's none of that stuff that goes on. With treatment, what we're trying to do, in a sense, is that let's just say, for example, that Maggie was, and another term we use is called the executive. The executive part usually is the one that's handling all the outside activities with the world outside. So she was old enough to drive her to the appointment she came to with me. Crash was a teenager, and Crash is over here, and what happens as a result of treatment is that we begin to create some kind of communication between these two parts. At first, in a lot of cases, it's one directional. Crash to Maggie. And Maggie might respond or say she hears another voice in her head. And in a lot of cases, it was Crash. Eventually, over time, we get this information or this awareness to be bidirectional. And then over time, with treatment, we begin to break down these boundaries between them so that eventually they're one. Okay? And so they share consciousness in that sense. DID is a split consciousness. That's another way to think about it. And so literally another part will come out and they will lose time. They don't know that they're there. The person perhaps that came into the appointment won't know that they're there until, in some cases, and I did it a little bit differently because I would tend to develop relationships with parts. And at times I would be very specific and say, I need to talk to Crash today. And because I had work to do with what he was up to and how destructive he was being. So, yeah.
Doug talks about how, all the parts together knew, the history
Right.
of what happened.
Yeah.
And I know, part of the
Yeah.
With the fragments that only come out when abuse is occurring,
Mm-hmm.
how do you go about, and the fragments are the ones that I'm assuming experience clearly.
Right.
How do you go about bringing out the fragment to discuss?
Yeah, sometimes with the part that is reporting of the event, a lot of times just in the report, the fragment will come out to fill in the gap, to fill in what actually happened. The process of therapy really is, in a sense, a sharing of information across all of the parts. And you know, when you think about it, if you have something really horrific that has happened to you and you don't want to remember it, and because if you do, then you know you make some conclusions about yourself and what will happen in your future, et cetera, et cetera. It just stays contained in that part. So in therapy, a lot of times we're inviting the report to be said so it can be shared with all the other parts, essentially. Yeah, Caleb.
So the gaps in the memory, that's not the same as something that would repress memory. It's just in a different cap.
Right. Yeah. Yeah. I mean, usually with a repressed memory, we're mixing terms is the problem here, because repression comes essentially from Freud and the idea that a memory or a conclusion or whatever is buried in such a way that I don't have any access to it. The reality is, in this case, is that they have access to it, but it's through another part. And you know, the other thing to consider, at least, is that with this, you might think of this as a little bit like a walking library, and each book has a different account of life for the person's life history. And so, in some respects, when I was certainly doing therapy, at times, I wanted to try to find a way to piece this history together. And so the initial point was them talking to me. My ultimate goal was them to talk with one another. And so, unlike what we have today, because today with computers and you know, word processing and all that sort of stuff, what I didn't have any of that. At the time, the closest thing we had, at least on the internet, was called community bulletin boards. And essentially it was asynchronous. You'd post something up there. It's a little bit like forums today. You post something in there, somebody answers it, and you get your answer. Well, essentially what I did with at least Maggie and a number of other my patients was I had them create a community journal. And certain sections of the journal were set aside for different parts. And if they wanted to communicate with one another, they wrote in each other's parts of the journal. And that was the beginning of trying to get communication going between various parts and what they were going through and what they were experiencing. Yeah.
So for the fragments, are they a choice, or it just kind of comes out during the situation?
Well, initially, it's an automatic mechanism. I mean, the kid doesn't say, okay, now I need to dissociate. The kid naturally does. And when it happens frequently enough, then in a sense it kind of congeals into a fragment that handles that particular event. And so it's not really a choice. It's really very automatic. And that's part of the problem. You know, Doug described the flat affect and the flat face and those sorts of things. And when you've been a therapist for any length of time working with them, you know the look. And their voice doesn't have to change or anything like that. You know they're gone. And generally, when I was active in working with them, usually my first question is where did you go? And a lot of times I wouldn't get an answer. And then who's out? And sometimes I would get an answer. You know, every therapist kind of has a different approach to it. I always operated under the assumption that having a name made it real and validating, and it was part of the process of integration, is that they were somebody, if you will. And so So I wasn't bashful about using names. Doug is not nearly as worried about that or anything like that. We had other reasons for asking for names and stuff. Usually, the interesting thing about it is usually you had a lot more power when you had a name than you did if you were just talking to an amorphous kind of non-named kind of entity of some sort. Yeah.
So was my usually proof that the only trigger that took place that caused her to change?
At least initially, yeah. At least initially.
How did that happen? How did that become the trigger?
Well, more often than not, for most of these people, think about what time of day do usually bad things happen? In the dark. And so darkness and nighttime was the trigger rather than necessarily just going to sleep. And so, it was kind of coincidental in that respect. And that was just Crash's pattern. That was how he would party. So, yeah, usually. In a lot of cases, the one way I described DID was it was the most sophisticated and exquisite pain avoidance tool anybody could ever have, because of the fact that they were hypervigilant. They were constantly keeping an eye on their environment for something that would be a threat. And so because of that, if I was in a session with Maggie and I would pause or I would sigh, oftentimes that was enough for her to go away. I mean, this is, not to minimize it or diminish it, but this is truly the scared rabbit syndrome. I mean, one false move and they're gone because they don't want to risk having anything bad happen again. And usually, depending on the situation, will depend what kind of part comes out. She had real combative parts. She had some very self-destructive, suicidal parts. She had a number of parts that a lot of the abuse that she suffered was at the hands of her older sister, and she was a missionary kid, and her family was in Ecuador, Quito, Ecuador. And her parents ran the HCJB radio station in Quito, Ecuador, and it touched all of Ecuador because it was on top of a mountain for one, and it was really very powerful to reach people with the gospel. Well, her older sister got involved with an occult group outside of Quito, and basically conscripted her sister to be engaged in the rituals that they did there. And in a lot of cases, what Maggie would do was her younger sister, her older sister wanted to involve her younger sister, and essentially she offered up herself so their younger sister wouldn't have to go through that stuff. And so that was a lot of the background for her of where a lot of the abuse and all the other things happened. Once they got back to the States, she was no longer under threat, but she didn't know that. I mean, as far as she was concerned, she was still in danger. And, the longer I got to know the family, I have known Maggie since she was 22. And that was, let's see, let me think here a second. That was 1989. So that would be 11, 20, what are we at, 17, 28 years. So she's now pushing her 40s. Is that right, 22? Yeah, no, almost her 50s. And she's had some significant health issues. She's had Cushing's disease, which attacks the adrenal glands, and has gone through some tremendous problems. She was always very heavy, struggled with her weight all the time. Well, lo and behold, what we found out was it was because of the Cushing's disease. And she would, right now she's pretty much apartment bound because she weighs somewhere around 350, 360 pounds and can't really get out anymore. Has had multiple grafts and all sorts of just health issues. And I've known her since that time, and the way she came to me as a client was that she went to see her therapist that she was working with, who was treating her for agoraphobia. So he wasn't even treating her for DID. And she went to the office of her therapist, and the receptionist said, "I'm sorry, but your therapist died last night." So she was traumatized by that, and then eventually she ended up in my office. I'm not exactly sure why, because it was a Christian clinic, and she was far from being a Christian. She was a Wiccan, and she was involved in witchcraft and a lot of other Eastern religions and things like that. So I think it just was because it was the closest. And then she ended up, with a greenhorn like me that I'd never treated or heard anything about MPD in all of my life. And yeah, we kind of grew up together. I learned the toughest parts about MPD and DID through working with her. And it was quite a journey. She started somewhere in the mid-20s as far as the number of personalities she had. She had a number of them that were satanically involved, and she had been through a variety of rituals and things like that. And by the time she left for Seattle near the time I was leaving Wheaton, and she had worked with the parts, and a number of the parts had come to Christ, such that we got it down to 10. And she would say she still has a wonderful sense of humor. And so whenever I get an email from her or whatever, she'll always sign it Maggie et al. Because they're in harmony now. They're not fused or integrated, but they're in harmony. And that's better than it was before. So yeah, that's the abbreviated story. If you want the real story, ask my oldest daughter. She has lots and lots of memories of me being on the phone virtually every night of the week trying to talk Maggie off the cliff all the time with suicide and stuff. Yeah, all right.
So is it possible to have a person who doesn't necessarily have different persons in them, where they're all the same person, but they have these split off, kind of?
Yeah.
You know what I'm saying?
Yeah.
It's all one person, but they have different personalities.
Yeah, I mean, if they have a continuous sense of time, then they would fall, if you look at the continuum that Doug gave you, they would fall in that category that we called dissociative disorder NOS. NOS stands for not otherwise specified. And they just don't fit any specific category, is really what it amounts to. We saw a number of people like that in the hospital as well, and they weren't as defined as this that we're describing here, but they would dissociate. They would dissociate, in a group session or an individual session or things like that. They may not lose time, so they didn't trade parts or switch, but they weren't there, and so. That would fall kind of in that grab bag kind of category that didn't fit into any specific kind of designations that we had. So, yeah.
You're talking about next time. I don't know how I was sort of but Maggie would obviously the dominant, she's
right.
Could the dominant person lose their dominance for an extended period of time? How long would these come?
Yeah, I actually, during the time that I was treating her, Maggie was missing for about a year and a half. And so Crash was really ticked off at that because he loved having the cover of being a part. But he had to deal with all the adult things that she had to deal with, and he was not happy with that at all. And other parts kind of showed up more when she went missing. She had gone through a pretty abusive friendship with a male, and she just kind of went missing for a while. And so the other parts the other parts generally have some skill. And during that time, she was living at home with her parents, so she was in a relatively safe environment. So the only thing that she left the house for was to come see me for therapy, which was twice a week, and that was pretty much it. She lived out of her apartment in her parents' house. So yeah, they can kind of interchange at times depending on the circumstances and what kinds of things tend to happen, and that's not uncommon at all. So yeah. Yeah, it would never come out. Yep. And a lot of times, as I got more accustomed to kind of the interior universe for her, she was incredibly artistic, and so like Doug mentioned, sometimes clients will map their system, and for her it was literally she kind of it almost looked like a map of Middle Earth. I mean, there was Mordor, where all the evil was and all the evil parts were, and then there was another place where some of the other parts that had come to Christ were, and then the others were kind of scattered in between. And so there were times where I'd ask, is Maggie there? Can I talk to her? And no, she was gone, and nobody, no other parts knew where she was, and so.
Did they know who you were talking about, though?
Oh yeah. They did. At that point in treatment, they did. Yeah, they did. So they knew who, and see.
So like the person never went missing.
No, not the physical body didn't.
Physically went missing.
No, the physical body didn't.
Oh,
just the part did. Right. Yeah. Yeah. Today everybody's watching, the Marvel comic universe. I was living that 20 years ago because it was a universe. It was a group of people, and you really had to have kind of an ability to think abstractly about where internally on that in their world were people, and sometimes they'd be close, which means they're more easily accessible, and sometimes they're really very far away. And it was, I don't know why I took to it. It was really pretty easy for me to track what was going on in her and a lot of other people. I had another client in the hospital whose all of her parts had exactly the same name. That was her best way to hide. So it was always the same name, but they were different people. And so you get fairly adept at noticing some really pretty small kind of micro expressions in people's faces where you can tell who's out and who isn't out. So you had a question, Sarah. I didn't get to you.
So I think I know the answer to this, but I'm just curious.
Yeah.
So like when a child is like first being abused and they first start using this disorder as a protective mechanism.
Yeah.
Is it more like it's happening and they're like they have an invisible friend almost, like kind of thing where they like are, it's like an out of body experience and they're watching this other.
Yeah. That would be very much what it's like.
Okay, so it's not like in that moment, this is not me, this is somebody else.
Yeah. I mean, it's happening to somebody else. It's not happening to me. And so, yes, it would be very much like that. I mean, the reality is it's not necessarily the disorder that they're using. It's dissociation that they're using. And they use it really very naturally. And at that level, I agree with Doug. I think it is a insulating, protective mechanism that children have because they have no power in most of these relationships to get away from what's actually happening to them. So in that regard, I agree with that perspective that he comes from. The kids naturally do that anyway. And usually what I like to point out is on the continuum of dissociation, there's normal dissociation, all right? Highway hypnosis. You drive a highway that you've driven 15,000 times, and you pass a mile marker, and then you are aware that you've already gone a mile or two down the road and you don't remember much. Highway hypnosis. Sometimes you'll see changes you'll feel changes in limbs, like your hands are really heavy or things like that. That's a dissociative kind of experience. Daydreaming in class. A really boring class. Bye. I can tell. I can tell. So, I mean, it's a really normal thing. It's when it starts to disrupt everyday living, relationships, things like that we begin to say, now we're into the quote-unquote abnormal range. It's interfering with daily functioning and things like that. You got to follow up? Yeah.
Do you just say it's like similar to like you're in a play and you really take on that role, like as if you're that person?
Yeah, it's different because you're voluntarily taking on that role. In this case, the process has become so involuntary that in most times the person doesn't know when they've switched. Now, for somebody like me, I generally can tell when somebody has switched. Some DID folks are pretty classic in their switching, which we called it a swoon switch. They'd kind of look down and close their eyes and look up, and the minute I saw something like that happen, I'd be watching their eyes, because their eyes would give away. They were trying to orient themselves to where they were and who they were with, and your eyes give that away usually. You can tell when somebody's disoriented by how they look around a room and how they look at you and all that sort of stuff. And that same thing would happen with a DID patient. So they don't know. A lot of times they don't. Other times I've had them switch seamlessly. And the only thing that betrays it is their language. How they talk is what tends to betray it for me. So, did you have a question?
I did. Okay,
Yeah.
So just to kind of clarify, so kids that are being abused, like, can they dissociate to the point where they don't even remember the abuse has happened? And can they go into adulthood and they have issues, but they don't know why because they don't remember the detail?
Yeah, and that's really pretty common actually. And you talk to most therapists, and a lot of them will say when they're treating somebody who's PTSD or something like that, is that a classic kind of profile would be a woman who was sexually abused as a little girl, doesn't remember any of that, and she goes on and carries on life, gets married, has kids, and when her daughter passes the same age as she was when she went through it, suddenly all these memories come out. And that's a fairly common, I wouldn't say it's just commonplace, but it's a fairly common profile to have.
So you say that they could go through it and not even have extreme symptoms, but then that just triggers it?
Yep, exactly. Yeah, Katie.
So in the case of Maggie, when she turns wolf-ash, how does that change her gender expression?
Good question. Crash was an interesting character. For one thing, Maggie, the host, wore glasses. Crash never wore glasses and never seemed to really be impaired. Now, it wasn't like I had him take a sight test, but he never seemed impaired, and he would dress in such a way to downplay all of the sexual characteristics of a woman, and so combat boots, fatigues, the kind of jacket he'd wear would be to cover up the clear indications of being a woman, and where he was going in downtown Chicago, because we were talking about drag king and queens, they were all over the place on Wabash. So he fit right in. Nobody would even pay attention to him. I'm referring to something we were talking about in human sexuality today, and one of the categories of transgenders is drag king or queen, and it's somebody who cross-dresses for exhibitionistic purposes. And there are areas of downtown Chicago that are known for that. And that's essentially where he went and partied and had a good time and everything else. The other part that I think I probably have to mention is these parts played a very, very important function in the survival of this person. In a lot of cases, and you heard Doug mention this, is that it's not uncommon to have a DID patient with a persecutory part, a part that persecutes other parts. And it would be very much like, are you familiar with the phrase the Stockholm Syndrome? You've heard that before? The Stockholm Syndrome essentially is people that are imprisoned for any length of time, and they begin to side with their captors in order to have better treatment, essentially. And it was first really identified or popularized, I guess, would be with a young heiress in the late 60s, early 70s by the name of Patty Hearst. She was kidnapped by the Weather Underground, and essentially she became one of them, and the next sighting, because she had disappeared for a long period of time, the next sighting was her doing a bank robbery with the group from the Weather Underground, and she espoused all the same philosophy and everything else of this kind of terrorist type of group. The Stockholm Syndrome is seen a lot in DID, where the parts are aligned and behave like the perpetrators, even to parts internal, and that's a lot of times the self-harm, self-mutilation. Some of those things that I saw were done by persecutory parts on the body. Okay, now a really fairly frightening one that I had, and this was with Maggie, where I had a part who kind of hitched a ride into my office because he wanted to try to intimidate me. And so when Maggie sat down, there was an immediate switch, and I wasn't real sure who it was that I was talking to. I couldn't identify the part. And essentially, as we started talking, I noticed the part reaching into her bag that she always carried, and out came an X-Acto knife. And essentially, it began this ransom-like talk and held the X-Acto knife to her throat and said, "I will kill her if you don't let me go." And unfortunately, all this, the receptionists, secretaries in the office, I was stuck in this session. I could not get out, and so the secretaries came. In a lot of cases, and it still is even. You'll see it even in my office. Is I tend to put chairs where people sit so they can't be seen by people walking around outside. It's me with confidentiality. It's kind of a habit of mine. Well, she was in that same situation, and so the receptionist couldn't see what was going on. She looked in the slot on my door, and I basically said, "Don't bother me. I'm busy." She already knew this patient, who it was. And there was one button on my phone that I could push that said, "Cancel everything else. I can't get out of this. Just leave me be." And the one thing I knew about DID is parts that are not out a lot, like fragments, because this was a fragment. Fragments that are not out a lot don't have a lot of staying power. See, the parts that are out a lot, they're accustomed to being out in the energy and kind of the psychic energy necessary to function out in the real world. But there's a cost. There's always a cost. DIDs, a lot of times they'll fall asleep because of all of the energy that it takes to run, if you will, apart out in public, if you will. And I knew this was a fragment, and I also knew I had never seen it before, so I made the guess that if I hung with it long enough, it would go away, because it wouldn't have the staying power that Maggie or any of the other parts had. And And so we continued to have a conversation. I kind of wandered around trying to figure out who this part was or this fragment and what was going on and where they came from and how they what memories they had. And essentially, really all I was doing was buying time. It was really all I was doing. That's all all I was thinking of was what other question can I come up with to keep this part talking. And sure enough, about 2.5 hours later, and the X-Acto having cut enough of her skin that there was blood coming down her neck, it went away. And
you just like sat there and let that happen? You just like had to like be present in that?
Yeah. Yeah, because I knew if I lunged, it would have done it. It would have done it. So I knew that I couldn't interfere. I had to find some other way to stabilize the situation. And so, yeah, I basically had to sit there and watch. And it went away. And then I made my move and got the X-Acto knife and called 911. And the ambulance was there in 5 minutes, and she was carted off to the hospital. But I mean, that was at the height of the worst part of what I was doing with Maggie, and at the worst of it, she was usually in the hospital about once a week, starting from Halloween all the way to the middle of January, which is the final kind of satanic calendar, which is January 20th, which is a holiday in the satanic calendar. And I knew the calendar so well that I knew when things would probably quiet down, and that was the case. So she was in the hospital almost regularly and had to deal with stuff like that. So, yeah. Yeah.
One, just the fact that she was in her glasses again, altered and now is another. Could an alter have like a medical something going on with them, like so thin? Like how could it happen?
Well,
It crashed his belt or not.
perhaps. I mean, nobody. I mean, I wasn't lining up an optometrist to check, but I worked with another unit in Chicago run by a psychiatrist, and his contention was that parts could actually the physiology of the part would actually change. And he had evidence enough with doing PET scans that when a part would come out, the brain would be activated differently, entirely differently. So his contention, I'm not sure I bought it, but his contention was that her eyesight changed. I don't know physiologically how that could possibly happen if somebody is nearsighted and becomes 20/20, but there certainly were plenty of instances, and Doug probably would verify this, where scars would become more pronounced with certain parts being out and things like that. That was not unusual in the world that I lived in for that decade. So, yeah, Autumn.
When you're talking about her part of crash,
Yeah.
now she was kind of with the drag
Mm-hmm.
kind of thing. Was her sexual behavior changed?
Oh yeah.
Other things?
Yeah. I always kind of stuffed the question in my mind, what's it like being a male living in a female body? I just never got around to asking that. I was always curious as to what did they do in the bathroom? And usually, what I pieced together was usually they dissociated for toileting and then dissociated back. So, yeah, Eric.
So two questions. The first one, if would you have, looking back, would you have changed the way you acted in that situation? And then,
No, I really had very, very limited options. I really wouldn't have done anything. I think and I did after this whole episode, was that because we didn't have cell phones. I mean, I had a cell phone that was a defensive weapon. I mean, I could hit somebody with it and kill them. So I really didn't have that. When they developed speed dial in cell phones, I thought I'd died and gone to heaven because I could hold one button and be able to have somebody listen in on what was going on. So I really had very limited options available to me because the part was so deadly that I really had to stay front and center and keep an eye on where this thing was going to go. And I had already worked out in my mind, if she went through with it, what I was going to do. What kind of clothing did I have with me that could cover the wound and at the same time get to the phone. And I also had the protocol worked out on my head that if this part was going to go away, what my next move was going to be. And how I could get other people involved to help me, but I didn't know like I said, I didn't know what I was getting into when I started working with MPDs. But then once I started working with them, I found that I seemed to be pretty good at doing it, and I had my own version of hypervigilance so that I knew what I was looking for and how to be ready for anything that could happen. So I don't know that I would have changed anything in that. And I don't really know that anybody could have done anything different. I think the one thing that would be different now is that I probably would not have as severe and complicated patient as that seen in outpatient treatment because it's way too uncontrolled. So, yeah.
How is it that some parts of you exist and the person isn't? And how
Yeah. Well, when I start talking and answering this question, just imagine all the theological heads down at the end of the hallway exploding. Because it blows up every concept theologically that they think they've got figured out. Some of it is this. Is that, theology assumes an intact person. If you quote me, I'll deny it. So in a lot of ways, with DID, it was really pretty simple because they were so separate from one another that even their relationship with Christ or not was uniquely theirs. It was part of that behavioral history I was talking about before. So nobody instructed me in it, but I thought the one thing that could band a lot of these parts together was Jesus. So if I could figure out a way to get them aligned with Jesus, then I'd let him take care of the rest of that craziness, and then we could also align them against the evil that was also present. And so I mean, so at one level, it's pretty easy that it could be that way. In the secular setting, usually, particularly because of the hospital we were in, it was a secular hospital. But they couldn't argue with our results, which they really didn't care about. What they couldn't argue with is that we were a money-making unit. I mean, we were full all the time. A lot of the other units in the hospital, particularly, because at that time there were freestanding psych hospitals. You don't see those very much around here anymore. There might be 2 in the Denver area that I know of, maybe 3. But all the other units were always low on census. They were always scrambling to have enough staff and everything else. We never had that problem. So even from a secular point of view, we spoke their language because we were making money for the hospital. The other part of it was the psychiatrists really couldn't contain their fascination with what we were doing because they knew we were treating DID, but we were treating it from a Christian worldview, and they were really pretty fascinated about that because we were charting territory that nobody else was charting. when it came to addressing the demonic, addressing the spiritual components of it, addressing in a pretty standard way the treatment with DID and things like that. And so, there was a certain fascination they had. It wasn't like they were going to come to Christ as a result of what we were doing, but they also couldn't deny that, a lot of our patients walked out in very, very different shape than they walked in. And a lot of that was because our entire program was focused around Christ was the center of it. It was taught in our didactic classes. It was part of our group sessions. It was part of our individual therapy. It may not have been openly that all the time, but it was always that in all the conversations, and even the community and the units were functioning that way as well. So as long as we were making money, they left us alone, which was just fine with me. But, even today, DID is a controversial subject. A lot of therapists, particularly secular ones, because they're physical monists, they don't believe there's a spiritual. So because of that, then, it doesn't compute, even with DID, because in a lot of quarters, psychiatrists would say that if you're working with parts, then you're making them more real than they are, and actually these patients are really borderline personality disorders or something else. There is no such thing as DID. I'd love to introduce them to Maggie and see what they do with that. But yeah, that strategy that I landed on was completely accidental. It just made sense to me, and it ended up being kind of the unifying force for getting her from 35 or 40 parts down to 10. So I've been very fortunate in the work that I've done with DID and MPD that I probably have somewhere in the vicinity of maybe half a dozen to 10 patients that I've been a part of their complete integration and fusion. A lot of them, because of the sheer number that I had a role to play, but not their entire treatment. So I didn't really get to see all the stories play out. But yeah, it was kind of interesting. So yeah, Ashley.
How do you tell people how to react when someone with DID changes parts? Like Maggie's parents, if she would change parts in front of them, do they just act like they don't know, or like what do they do?
Yeah, I usually her parents, they were only one part was ever out with her parents, so they didn't interact with anybody other than what they thought was her. Now, I certainly met with friends of hers, and we did a fair amount of talking about, if she switches, what do we do? And usually my answer is nothing. Treat her as if she's still Maggie. Leave the switching and the parts to me, and let her figure out the rest. Because the system of parts and DID and everything else has worked to keep her alive and survive. And so good people that are friends are not going to be a threat. They're not going to hurt her in any way. And so if they can be understanding and give her the time she needs to kind of find her way back or get anchored again, or I would rarely instruct friends to say, can I talk to Maggie? I'd say no. Just treat her as if that's who she is, because that's how they interact with the world anyway. Most of the time people that you interact with as DID, you're not going to know it. So, they know how to function in the world without people knowing who they are. And that's kind of part of it. Yeah, Hannah?
On the lower end of the spectrum, with PTSD, people forget different details of the traumatic event, or they will dissociate when talking about it. How do you differentiate between somebody just having PTSD and somebody having PTSD and a lower end dissociation?
Well, I think it's that kind of that added component that you mentioned, when they dissociate in telling the story, or they, there's kind of this news report feel to how they talk about it. Then usually we're adding that in. It's so common in PTSD that generally we assume that it's there somewhere because that's part of the survival that goes on. At least 2 years ago when I had the military guy come and talk to this class, he mentioned the same thing with some of the soldiers, that the only way that they really could contain either the fury that they felt or the overwhelming fear was to dissociate. And a lot of times they dissociate in front of a TV set and whatever. In some of the movies, it's actually conveyed. If you watch American Assassin, for example, Chris Kyle, it's portrayed in there toward the end after he's back in the States. He's replaying, and in a sense, in a flashback, while he thinks he's watching the TV, when in fact the TV's completely off, and he's in the midst of a firefight. And so, I mean, generally speaking, we kind of assume that there's going to be dissociation somewhere in PTSD anyway. So, but usually it's the flattening of the affect, the kind of a disconnection with what's being reported. Those are usually the signs for it. So, yeah.
Is the primary reason why you dissociate is protection rather than alternate for, like, if I would protect yourself, if you were doing it to protect?
Well, and you're, I mean, there is a category called protector parts and persecutory parts. And so, again, some parts can be very specific in function, but fragments a lot of times will be that as well. And sometimes it's the message has been communicated that they deserve punishment. And so the part enacts that on the body. And that's the persecutory part of the system, if you will. The way that a lot of times I would conceptualize working with DID was like working with a family, and that's why I use the word system. They had rules of engagement, they had certain functions that they played, they had certain roles that they played, and my job was, in a sense, to try to figure out how that whole system worked. So, but it's not uncommon to find, like Doug said, persecutory parts, the parts that play out the punishment, and then there are other parts that function to protect younger parts, and a lot of times you'll have pairs, and he said they kind of cluster together. It's not uncommon to have older parts and younger parts, and the older one's job is to protect the younger ones. So the variations are endless, but there are certain themes that are pretty common that you tend to see over and over again with DID. So we have one last question. Yes, ma'am.
So with like the older parts and the younger parts, do they like develop as the person grows older? Because like it sounds weird to have like a 5-year-old who understands like an adult part and like just creates that.
In other words, do they age? Do they age?
Yeah, like mature kind of.
What I have found is once the person gets into therapy, they age. But when they come in, a lot of times they're frozen in time, and they react as if that time. It's like it's in a sense they're in a constant flashback. That part is, and so I have seen plenty of instances where parts have grown older as the person ages. But usually it's only when they're recognized and part of a therapy treatment setting. So, what normally brings them in? Usually some kind of crisis, like a self-harm incident or a suicide attempt or something like that.
And they're like, I'm aware of it.
No, usually not. I mean, Maggie wasn't. She came to me thinking that she was going to get treated for agoraphobia. Agoraphobia is the fear of going outside, essentially. Yeah. So she didn't know.
Something like little that they're like, I need to work on this.
Yeah.
But they don't realize that.
Yeah. No. I literally what I have had happen is that, particularly with Maggie, and I don't know if you guys want to hear this. You can. If you don't, you can leave. What I have literally had happen was I suspected that something was up with her, and I wasn't real sure, and it took me about 6 months to collect data about what was going on with her, and losing time and different identities with the voicemail and all those sorts of things. I was not going to jump on this any faster than I could be actually confirmed of it. And we had one conversation that I still recall and say, do you ever hear voices in your head other than your own? Yes. Have you ever lost time, like days? Yes. I hate to break it to you, but I think you're an MPD. I think you have multiple personality disorder. And the interesting reaction was, it wasn't screaming in terror, running out of the room. It was relief. It was like, really? Because people thought she was psychotic because she was having voices in her head. And she wasn't psychotic at all. It was the voices of her parts that she was hearing in her head. And so there was a lot of relief, and suddenly she had a lot more hope than she did before because she had clarity about what her experiences were like, what was going on. So,
Whoa, what a crazy life.
have fun on the weekend.